welcome you all to this series of webinars. And I hope that you already know that we have already talked about liver, gallbladder, pancreas, and today is the place for spleen, the forgotten organ. So I'm inviting you to a very interesting webinar on pathology rarer encountered in clinical practice, but where ultrasound is very useful, you are going to see. And I hope that you are going to enjoy the presentations. We are going to start with a lecture regarding ultrasound of the spleen, the examination, anatomy, and pathology. The lecture is going to be given by Dr. Corinna Trenker, and it's my pleasure to introduce her. And as I understood correctly, we have a recording of her presentation, and I'm inviting you to look at it. And if you have any questions, feel free at the end to ask the questions.
Dear students, it's a pleasure for me to give this education lecture today about ultrasound of the spleen, examination, anatomy, and pathology. My name is Corinna Trenker. I'm working in the University Hospital in Marburg in the Interdisciplinary Ultrasound Center and also in the Department of Hematology and Oncology. First of all, many thanks to Professor Dr. Christian Görg. He is my teacher for many years, and he providing me some ultrasound figures for the lecture.
If you are there, maybe if not, we can comment.
Alina, we have some questions in the chat. We will look there. Better now.
We didn't have one until now, but I hope we are going to have.
No, about the quality of his pictures, yes.
Yes, but
No.
for me it was perfect.
Are there a question in the auditorium? Are there some questions to that lecture about basics and also about findings in the spleen examination?
No questions. Maybe we can comment a little bit.
Then I can continue with a short presentation about the journal club. Normally we make a journal club, but sorry for that. Today we had a short misunderstanding with my students, and now I give you the paper link and what is the main importance information about that. And I like to share my presentation. One moment. Okay, it was a paper where also Corinna Trenker and Christian Görg, you heard about them, were involved. Christian Jansen also, and Elena Simona Ionescu, and it was published by Christoph Dietrich. It is published in 2021 about a position paper of the WFUMB about the incidental findings, how to manage spleen incidental findings. And for me, important was that we can find that incidental findings nearly in 1 to 3% of all of our patients. And a lot of, they give in their paper a lot of information about the literature. It's a classical review of that authors. And the main important findings are the Splenomegaly. And they also gave us the information what to do then. And the next are accessory spleens, like you can see here in that pictures, most often one, but also sometimes more than one. We know that from other studies by CT and other imaging methods that we can see very often, nearly in 4 to 7% of all of our patients. And the accessory spleen, that is another point. And we have also, we can see a lot of focal lesions there. They described it in their paper, that are cysts, normal cysts, and cysts with inflammatory content like abscesses, and also solid focal lesions like here. That was a patient, one of my patients with sarcoidosis. Because normally the people, they have a clinic, the incidental findings, that means you can see that if they have no clinic and no laboratory signs. You have seen that picture already in the lecture of Corinna Trenker. That is from the study of Christian Görg and the people, the team of Marburg University, and they found 550 splenic lesions in a lot of examinations, and most of them, they are working in an oncological department, most of them were lymphomas, infarction, metastasis, cyst, rupture more seldom, hemangiomas and other. And what is important in that paper, and that's why we recommend that paper, that is that you can see what is you have to do if you see a focal lesion, a focal splenic lesion in B mode. And that is a workup strategy, what they recommended for the focal splenic lesions. They told us, or they recommended, if you see multiple splenic lesions, you need further diagnostic workup. You have to think about lymphoma, sarcoidosis, abscesses, whatever. If you have a solitary splenic lesion, then you have to differentiate its cystic one, and then no further examination, no further diagnostic. And also, if it is an echo-rich solid lesion, then they recommended a follow-up. You can see that here. But if you have a progression, then you need more more diagnostic. The most important lesion are the echo-pure solid lesions, and then it's useful, and we like to discuss it after the next lecture. Then it's useful to take SOIS or contrast media ultrasound and to look for lymphoma or other solid lesions. It's important that and if you see an hypoenhancement in the late phase, then they recommended further diagnostic like puncture or whatever, and they say that could be it's in lymphoma. If there's an hyperenhancement in the late phase, then they make a follow-up. That was the workup strategy of the authors of that WFUMB paper, and you can see it here. I hope you can read it. You have to look at the website of the WFUMB and then go to the ultrasound in medicine and biology in the journal, look for the publication about incidental finder spleen, and you can download the paper. It's for free, and I think it's a very good recommendation what to do with incidental findings. That was very short, but next time a little bit more expansive. Thank you.
Thank you, Professor Nuremberg. We have a question from the audience. Maybe, I don't know, we can answer it now or we can answer it after Simona's talk. How to differentiate splenic abscess versus splenic infarction?
I think my cases will give the answer.
Yes, I think the first answer before we see the pictures, and they are a little bit different, is at first you have to ask for the clinic. What is the clinic and what is the anamnesis? And we are doing clinical ultrasound. We ask the patient for the history, and then we look at the picture. And sometimes, and I'm sure that Elena will show us interesting cases about that, we use, for instance, the contrast media ultrasound. Yeah, I think we can go on and we can come to the next point, Alina.
Yes, thank you. So it is my pleasure to introduce our colleague, Elena Simona Ionicescu. She has a huge experience in spleen ultrasound, and she is going to present us, I'm sure, some interesting cases. So enjoy.
Thank you for the invitation. I prepared 8 cases. I hope to find them interesting. My first case, it's 46-year-old male patient with liver steatosis and no other previous pathological conditions, presented in our department for usual reevaluation, but with no recent ultrasound performed. It was asymptomatic with normal biological data. On B-mode ultrasound, you can see spleen, mild increased spleen with focal unique lesion, hypoechoic with well delineated but with irregular contour. Our question was, what is this lesion? What do you think about this lesion? Could be a benign lesion, could be a bulky lymphoma, a splenic malignant primary lesion, a granuloma, or you ask for other imaging investigations. We perform CUS, and on CUS, our lesion was iso-enhancing in the arterial phase, but with a rapid washout, inhomogeneous washout in the venous and late phase. Again, what is your diagnosis?
The students should answer.
Yes.
The recommendation is that everybody, you can open your microphone now. You can say
Yes.
it, or you can make a proposal, or you can write it in the chat. Please do it. Work with us.
So it was a difficult case because the lesion seems to be a bulky lymphoma lesion. According to the guidelines, it was suspected for malignancy. We performed a splenectomy, and the results was unspecific granuloma. It was a benign lesion. Turning to the guidelines, we can say it was lesion, an asymptomatic lesion. An asymptomatic patient could be a benign lesion, but it was the risk to be malignant, so we prefer to perform a splenectomy.
Thank you, Elena.
Yes.
I think for me it was a surprise. I would.
Yes, it's a surprise.
I thought because you give us a recommendation that the EcoPure with hypo enhancement EcoPure lesions and bulky lesions, it looks like a bulky lesion. What do you
Yes.
think about a biopsy? What is your opinion about biopsy?
This is
Is
what
it
I
an
wanted to ask
option?
also.
Is it an
Uh,
option to take if the case is unclear? You can take a biopsy of spleen.
Yes, but depends on the surgeon or interventional radiologist, if every department has. This case, I have this case in 2010, and at that moment, splenectomy was the option.
Okay, you are right.
Mhm.
In the past, the first choice was splenectomy. Today,
Splenectomy, yes.
we would discuss biopsy. The risk of biopsy of spleen is a little bit higher than biopsy of liver or other organs, but it's low. It's lower than 1%, the bleeding risk. And if the coagulation is okay, you can do it. You have to discuss it with the patient, but you can do it. What is the idea of the participants? Have you some additional questions or some comments?
That was also my question, but I think I think it was not a mistake, and I don't know how easily it would have been to diagnose a granuloma only by biopsy as compared to splenectomy, especially because we thought that probably it was a lymphoma. My suspicion would have been lymphoma, and
Yes.
maybe it's not a bad thing that we took out the spleen.
Okay, thank you.
Yes.
Next case.
Next case. It was a 71-year-old male patient with post-traumatic splenectomy in 1951, known with benign liver lesion since 2001, with follow-up in the county hospital. After one routine ultrasound examination, MRI was recommended, and MRI described thickening of rectal mucosa and few peritoneal nodules. So the patient was referred to our clinic for more investigation with highly suspicion of malignancy. The patient was asymptomatic, no other previous pathological condition were known, and with normal biological data. So we can see the images. This is the liver. This was the lesion. This was the feeding artery of the lesion. So it was quite well delineated lesion. Seems to be at the periphery of the liver. What do you think this lesion might be? A hepatocellular carcinoma, a liver metastasis, liver adenoma, an ectopic spleen tissue, or you need other imaging investigations. So we have an answer. Liver metastasis. Okay, let's see what CUs call. What
We had also
some
another,
we
yes.
have two cases, two
More answers.
students who answer ectopic spleen tissue. So what CUs show us? A homogeneous arterial hyperenhancing lesion. without washout at 2 minutes after injection. And at 4 minutes after injection. And as you can see, a capsule can be seen, a non-enhancing capsule around the lesion. What is your diagnosis? Again. In this case,
some answers in the chat.
yes, one answer. Again, liver metastasis.
Yeah, and before one was the idea of ectopic spleen.
So, laparoscopy with core biopsy was performed, and colonoscopy. The laparoscopy proved normal splenic tissue, accessory tissue, and colonoscopy non-specific inflammatory changes on rectal mucosa biopsy. So our final diagnosis was ectopic spleen tissue with particular localization. About the enhancement of the spleen, the splenic lesion, I want to point out that for CUs in spleen, the contrast agent dose is half of liver dose. So with the dose for liver, the lesion appear hyper enhancing. So that's explain the hyper enhancement of the lesion on arterial phase. As you know, the splenic tissue remain enhancing for more than 6 minutes after injection. That was also proved.
Can I comment a little bit?
Yes.
I wonder if you had performed also a CT, because in CT the spleen has in arterial phase zebra enhancement. It's a typical enhancement of the splenic tissue that is quite pathognomonic.
It's not found in all ectopic splenic tissue. We can find a homogeneous enhancement and not especially zebra pattern.
Okay. Very interesting case.
Okay. The chat. Hepatic enhancement is shorter. Yes, the hepatic enhancement is a little bit shorter than spleen.
And what do you think is there now? Do you think we can only use the contrast media ultrasound to say, because of the long time enhancement, that is an accessory spleen? Is it enough? We don't need another imaging method today?
I think yes.
Yes. Okay.
I think yes. Yes. Next case. Professor,
No,
please.
Okay.
The next case. The next case, it's a 48-year-old female patient with liver cirrhosis, with splenomegaly, with hypersplenism, with therapeutical partial ablation of the spleen 1 month before examination, who was referred to our clinic to be included on the transplantation list. Our examination was centered to prove the patency of the splenic arteries, because for liver transplantation, the main one of the important condition is the patency of the splenic arteries. So, what did we found on B-mode ultrasound? An intensely inhomogeneous spleen. On Doppler, we can see some vessels with arterial sign. What do you think? I think we can't prove the patency of the splenic arteries only on B mode and Doppler ultrasound. So we perform SEUS. We have some problem with the connection, I think. So
It's okay. I
prove,
can see it. I can see
yes. We prove the patency of the splenic arteries in this particular case. Okay. Another case. It's a 72 years old female patient known with VHC hepatitis, non-responder to interferon and ribavirin therapy, referred to our clinic to initiate interferon-free therapy. We can find on B mode ultrasound another inhomogeneous spleen, quite similar to the spleen that we have seen before, and some round lesion that might be adenopathies, but might be accessory spleens. What do you think this spleen is? It's an extended infarction of the spleen. It's a splenic lymphoma, splenic metastasis, or splenic granulomas. Extended infarction. Let's see contrast. Let's see contrast and enhanced ultrasound. Yes, yes, please. Yes, Alina. The arterial inhomogeneous enhancement is non-specific, especially in this case, but as you can see, very fast. There are multiple washing out small lesions in the entire spleen. Very fast. This is 1 minute after injection. and more than 3 minutes after injection. What is your diagnosis now? Granuloma, lymphoma, or metastasis? Lymphoma. Yes. Splenectomy was performed, and diffuse non-Hodgkin lymphoma with B cell was revealed. What can I say? Counting only the serious images, the diagnosis of granuloma could be possible. But in this case, we consider the pathology of the patient, the history of the patient, because VHC hepatitis it's in many cases associated with non-Hodgkin lymphoma, with biological data, with histology. So only on serious we can't prove the diagnosis in lesions with washout. So there are multiple lesions. There is a pronounced washout. So the other investigations were necessary. So counting only serious, the colleagues who said granuloma or metastasis did not answer wrong, but we must see the all context, all the situation.
Can I comment a little bit?
Yes.
I don't think that without taking down the spleen or a biopsy would have solved the case. So I think, again, that splenectomy was a correct answer. And I think mainly the role of CUS was to tell probably it's a malignant lesion, and basing on probabilities, lymphoma. This was also my first suspicion, even that I haven't seen all the case. Of course, when you see the patient, and if you have any other suspicion that can be somewhere another primary tumor, you can think also of metastasis. But what I wanted to ask you is, because it happened to me in clinical practice, I had a patient that had anemia and had a spleen, a large spleen. It was performed a CT scan that said that the spleen is large, and that's all. The contrast enhanced study was pretty the same like the image that you have shown us. So there were multiple lesions with washout. We repeated the CT scan, and the lesions were not visible actually on CT. And I wanted to ask you if you experienced such a situation where the contrast was the only method that showed actually that there are some lesions over there.
Yes, I have a patient with lymphadenopathy, inhomogeneous spleen with multiple lesions. CT scan performed at 1 week after contrast enhanced ultrasound said that there are no lesions in spleen. I saw again the patient, and the lymph nodes were almost disappear, and the splenic lymph nodes were reduced in size. We suppose to be some some viral pathology.
In my patient, was proved to be lymphoma because we made splenectomy in the patient, and I really don't know why the lesions were not visible on CT.
In our cases, it was the short time period when we have lymph nodes, and after that, I mean, almost in less than 2 weeks, we don't have any lymph nodes.
Excuse the question. Is it possible that in B mode, the spleen is very homogeneous? You can't see a focal lesion. And if you use then contrast media, you see the lesions like in the liver? Or you haven't seen that?
I think it's the next case.
Okay.
Yes. Oh, I have a problem with connection. No, it's not this case, is the next case. This case is 63-year-old male patient with prolonged fever on unknown etiology, known with colonic polyposis and aortic valvular insufficiency, who was admitted in our clinic. Can you see me? Can you hear me? Yes.
Yes, yes.
In our clinic with marked asthenia, weight loss, and left flank pain. On B mode ultrasound, we see large spleen, 70 centimeter, with a hypoechoic peripheral lesion. Hypoechoic, less well delineated. As you can see here, without a Doppler signal inside. So what is this lesion? Splenic granuloma, abscess, lymphoma, infarction, hemangioma, metastasis, or other imaging investigations are necessary. Okay, okay. Yes. Yes. Let's see. Contrast. Contrast enhanced ultrasound. It was a non-enhancing triangular lesion without enhancing on the walls. Without washout on the walls. So this was an infarction. An abscess is most likely similar to the liver abscess if we talk about a bacterial abscess. This was a peripheral lesion with the base on the periphery and up on the hilum. So this is an infarction. In this case, we prove. In this case, we prove an infectious endocarditis. Infectious endocarditis is in many cases associated with infarction in peripheral arterial branches. So in kidney and in spleen, we can find small infarction. Finding splenic infarction guide us to endocarditis. The next case, 63-year-old male referred to our clinic with liver metastasis and splenic suspected malignant tumor with weight loss, rectorrhagia, pain in the upper abdomen. As you can see, this was the liver with many metastases. But in the spleen, we found, hardly found, homogeneous round lesion similar to the splenic parenchyma. What is this lesion? You will see, we want to see series. So, arterial phase. The hyper enhancement of the lesion. We have problem. I have problem with the connection. The lesion was not remain enhancing at almost 3 minutes after injection. Please let me reset the connection, please. No, I have no chances. This is.
But it worked.
It worked, but
yes,
very low, very low. So it was a homogeneous enhancement.
After 3 minutes, we have an enhancement.
Yes. And
ISO enhanced after 3 minutes. But what will happen later?
We destroy the bubble. Okay. We have a flash, and this is again the enhancement, the hyper enhancement of the lesion, and no washout at 5 minutes after injection. So we consider this type of lesion, it's a hamartoma, because hamartoma is described as splenic normal tissue around the arterial feeding after feeding artery. Sometimes may have some cystic lesions inside. So in many cases, the differential diagnosis between hemangioma or hamartoma, it's very difficult. So we can say it was a benign lesion associated with liver metastasis. We found the primary tumor on rectum. So we must think all the time that the splenic metastases are very, very rare. I found only one case of splenic metastasis, and it was in an poor differentiated adenocarcinoma. So it was certainly a splenic metastasis. In other cases, we must think at the possible association between benign splenic lesion and malignant pathology.
Thank you very much. It's very interesting. It's not of clinical importance, yes, because we have a metastatic liver, but it's we can learn about how the lesions, about the different flow in the lesions. We can learn from that.
Another question that could be put, it was if the splenic lesion was a primary tumor. But the contrast enhanced behavior was of the benign lesion.
But my question is, have you ever seen a primary spleen carcinoma, malignant tumor? I haven't seen that all the time. Very seldom. I also the opinion that the metastases are very seldom. If we can see echo pure lesions in the spleen, we have to think about lymphoma and the differential diagnosis, and we can use a clinic that is sarcoidosis. Do you agree, or is it?
I agree. Yeah. I have one case of the primary splenic lesion.
Okay.
As you can see, a primary splenic leiomyosarcoma that was associated with the liver metastasis and bone metastasis.
Okay, it's very interesting. I haven't seen that. Only.
Yes. Yes.
Thank you very much. It's very interesting.
Another case, a 62-year-old male patient with liver cirrhosis with a splenic lesion, incidental finding. You can see a hypoechoic lesion with intense Doppler signal with few cysts. It seems to have some few cysts inside. We perform CIS. As you can see, intensely hyperenhancement, arterial hyperenhancement. No washout in the venous phases. And at 4 minutes after injection, slowly wash out. And at 6 minutes after injection, same slow washout. What is your diagnosis? It was definitely a benign lesion. I followed this lesion. There are already 3 years since I followed this lesion. Is unchanged. With my colleagues from CT said that is a hemangioma. I said it's possible hemangioma or hamartoma lesion. It was
I think it was very similar to the liver hemangiomas.
yes, yes.
It was
I think it's
going. It was closed. Yeah, the window
yes.
was closed.
Yes, I think hemangioma.
It looks similar.
Mm-hmm.
It's benign. That is important.
Yes, yes, that's certainly benign lesion.
The question is, can be an hydatid cyst?
No, hydatid cyst is non-enhancing. Not the walls, not enhancing of the walls, not enhancing of the content of the cysts. It's completely unenhancing. At CUS, it seems to be simple cysts.
Okay.
Okay. And the last case, a 70-year-old male patient with B-virus liver cirrhosis, left abdominal pain in recent history. This was the spleen. We can see here inhomogeneous, quite well delineated area. Our question was if it's a perisplenic hematoma or subcapsular hematoma, it's an active or inactive bleeding, or it's a splenic infarction. So we perform CUS. As you can see, this is the splenic capsule. Is moving the face to the wall, abdominal wall. And our final diagnosis was a splenic subcapsular hematoma, and it was an inactive bleeding at that moment.
It was very nice on the B mode because
Yes.
you used the high frequency probe.
Yes.
You can really see how the hematoma is compressing the normal.
The splenic parenchyma.
Yes,
Yes.
parenchyma. This is why I said subcapsular, because if you have the hematoma outside, you shouldn't see the parenchyma of the spleen, that it's with an irregular surface.
Yes. And we can see very nice on CUS the movement of the spleen.
Yes.
In correlation with the abdominal wall.
And it's the best method to tell you that it's no active bleeding.
Yes, because in active bleeding, we see small microbubbles moving into hematoma. We can see the point where the artery is traumatized. So those are my cases.
Thank you very much. Perfect.
Thank you.
Thank you. There
Thank
are
you,
no
Simona.
additional questions. And
Yes.
we learned a lot about choice in spleen examination. That is important to use it.
It's very important.
Especially
Yes.
in the differentiation of focal lesions. Okay, we come now. Please stop your
Yes.
the sharing. Stop the presentation.
Yeah. I don't know. Just a second.
Down,
Stop
you
share.
have.
Stop share.
Yes.
It's okay.
Stop
Yes.
share. Now I can see that is Niels Daum. It's one of our students. He and David, they prepared some questions in the Mentimeter quiz. Please, Niels, we have to start again to learn a bit. I don't know how many of the participants have took part in the past already.
Yeah, thank you very much, Mr. Nürnberg. So I also prepared a small tutorial. I will also share it here. Okay, one moment. Okay, I think you should see it here. Okay, perfect. Good. So welcome to our small tutorial here for the EFSUMB Mentimeter. So how you can participate with us, you have some different ways. So the one way is you can go on your phone or on your laptop and go on menti.com. And then you can also type this code here. It's 783017 and 8. Or the other option is to share it here with the QR code via your mobile phone. You will also have the code at the end. So the thing is, this is the screen you should also see. It's the Mentimeter screen here. You can join us with the number, which is also here on the higher side of the page. Here you can join us. What you see is also on your phone and also on this shared screen. And you can also interact with us here on the Mentimeter screen. So the instructions, videos, and questions are on your phone and also on the shared screen. And the results are also on the shared screen. So when you type here Germany, you can also see it in the screen. When you have some difficulties, there's also a slide where you can go back to the last slide, or you can also refresh the site. Exactly. So and this is also the QR code. And here's also the number. You can also join us. So we will wait around about 30 seconds that you have enough time to join us. And then we can also start our quiz. Okay, so we will also start. I will share my screen for the presentation. Okay, so now you should also see the shared screen here. Exactly. So also welcome to our WFUMB Students webinar, our ultrasound quiz. And we will also start with a small interaction. And what you can see is here a landmark. And you can also pin your country where you're from. And then we also have a good overlook from where you are here today. And yours has also the screen here on top, where you can also join while the quiz.
We see the QR still, Niels.
Okay. I think I have to.
You have to stop the share. Yes, now it's better.
That's better. Oh, okay. Perfect. Okay, so we have one round about Singapore, from Japan, from Europe some.
I think my point was in the Middle Sea. I couldn't find the right place. Okay, we have how many participants we have now?
Around about 12.
Okay, that's.
So we will start, and we also start with a easier question. So you have an ultrasound picture here, and the question is, what is the normal length of the spleen? So we will start with the first question here. We have 13 participants. That's perfect. And then we will also start. So how long is the normal spleen here? Is it 8, 11, 15, or 20 centimeter long? Already have 5 seconds. Yeah, perfect. 10 were also right. It's around about 11 centimeter and the normal spleen. Exactly, and this is our first real case. So you have also the spleen here, and you have a marked structure. And now is the question, what is this marked structure? What do you think? What do you think could it be? Is it a lymph node, a splenic tumor, a pancreas tumor, or is it maybe an accessory spleen? Exactly. 11 were totally right. It's an accessory spleen. We can also see it here. It has the same ultrasound structure here, and it's also here right now in the spleen. But you can also have some splenosis or so. Maybe it's so that you have some other events here around about the spleen. But this is correct. It's an accessory spleen in this picture. So we have the next one, and our focus is here on the echo-free zone in the spleen. We have 2 pictures here. Also right here, it's the same one. And the question is, what is this echo-free lesion? What can it be? So we have 4 options. Is it a lymphoma, a metastasis, maybe a cyst, or is it also a splenoma? Yeah, totally right. It's spleen cyst. You can also see it here, also in the picture below. You have an echo-free region directly here in the spleen, and a hyperechogenic region directly behind the cyst, which is the sign for also cysts and the body. Totally perfect. Good. Then we have the next one. We also have here 2 pictures. The first picture is taken at time 1, and the second picture at the bottom is taken 2 weeks later. And you have also history. You have a splenomegaly and a trauma in history. So what do you think could it be? Is it maybe an infarction? Is it a hematoma, an abscess, or is it a lymphoma infiltration? Time's up. And you were also right, it's an hematoma. We will also have a look here also when you have a fresh trauma, you have more hyperechogenic blood directly in the spleen. And after 2 weeks, it is a little bit consultated and you don't have the fresh echo hypergenitality here in the spleen directly. So it's 2 weeks after the first trauma where you have the fresh bleeding here directly in the spleen. Okay, so we have a moving picture here. And the question is, what pathology can you see in the picture? History is you have a young female with fever and inflammation signs. We have also some other pictures here. No, it's directly. So what pathology can you see in the picture? Is it a splenic cyst? Is it a lymphoma infiltration? Or is it maybe a sarcoidosis? Yeah, not an easy one, but 8 were also totally right. It's sarcoidosis, and you also can see the granulomas directly here in the spleen. You have multiple ones here, and the right diagnosis was sarcoidosis of the spleen.
Some additional explanation is a special view. Some of you have seen that we look in the spleen from inside. It's an endoscopic ultrasound picture. That is a view from the stomach, that is the wall of the stomach. And we look from the stomach direct in the hilum of the spleen. And we can see here the ecopure region.
Okay, so we're going on. And we have the first leaderboard. So at this time, Montana is leading directly before Snuggles and the Nikolaus. So at the end, we will have a look who gets the most points today. Okay. So now we have a small patient case. So it's around about 3 a.m. in the morning. It's very early. You don't have some coffee or so on. And you get called to a patient on a hemato-oncology ward. The patient presents fever pain on the left side of the upper abdomen, nausea, vomiting, and the patient has also fever. So you also made an ultrasound here. And this is the first of 2 pictures you can see. This is the first one. Maybe you can see it's also splenomegaly. It's a little bit bigger, but we also have a second loop. So we will also continue. And we have also here source. You can see here. Maybe you can also see a pathology here. So we will have a look one more time. Okay, So it's very early in the morning, and the question is, what is this in the spleen? What could it be? Or otherwise, what can you see on the ultrasound picture? Is it also a hematoma? Is it maybe an infarction, an abscess, or is it maybe a lymphoma infiltration? Okay, 8 said it's an infarction, and you were also totally right. We will also have a look here, and you see there's no contrast ultrasound which infludes into the spleen here. So you had an infarction directly in the spleen, and so you don't have any vessels or so that you can also that you have no reflection here directly in the spleen. So the other parts are also full of blood, but this is without it. So you were totally right, and also with the history of the patient, it's infarction of the spleen. Okay. So now we have another case, also some ultrasound loops, and now we have also 5 ultrasound loops here, and a little bit different picture than the others. So we're going on. This is the second one. Also with the source on the left side here. And we have the third picture. The fourth one. You can also see it's a little bit different to our last case. And also the last loop here. Okay, so the question is again, what does the patient have? So do you think it's a lymphoma? Could you see some multiple cysts there, or is it maybe also an infarcted spleen? Okay, 11-1 said it's a lymphoma, and it's totally right. You can also see it here very good. So you have some lesions here directly in the spleen, and when you also use here the source, you can also see the lesions here directly in the spleen perfectly.
The lesion seems to be cystic because it's a pronunciated washout. It's 4 minutes after injection.
Okay, so we also have a last one. So we also have ultrasound picture, and you also see you have the spleen here, and you have some irregular, irregular ultrasound picture here, and also a formation in the spleen. You also have some other loops, also with a psoas, and so we will have a look what we can see here. the last one. Also our last question for today. So is it an hematoma? Is it free fluid? Or is it maybe an abscess? What do you think? Okay, 9 said it's an hematoma. And you were totally right. But I think it's also a little bit difficult here to see it really clear. But you can see it here that you have a hematoma here. Okay, so we will also have a look at the leaderboard, and we will also have a winner for today. And I think the Nikolaus also got the win today.
Nikolaus is the best, yes.
So
congratulations to Nikolaus. Yeah, I think you have to wait 4 weeks. We come back in 4 weeks, a little bit before Nikolaus. We will meet again at the 2nd December, not at Nikolaus. Nikolaus is in Germany at the 6th December. It's the same in Timisoara, Alina?
6, yes, the same.
6th December. Thank you very much, Niels and David. Thank you very much for the Mentimeter. Congratulations to the first 3. Please say it not to the others. I was the 3rd. It's a good place for me. And who was Nikolaus? Show your open the window. Who is Nikolaus? Alina, you was Nikolaus? No.
No, I was Homer.
Who was Nikolaus? Please.
Ahmad,
We have Nicholas.
Yeah.
congratulations.
Congratulations. Very nice.
Thank you.
You have seen that the people listened to your lecture, Elena. Yes, they was perfect in using interpretation of contrast media ultrasound spleen. Okay, there's another one.
Please switch off the microphone.
Yeah, that was Alina. Okay, we switched off. We come to the end. Thank you very much, Elena, for the very nice presentation of the cases. Thank you very much, Niels and David and Alina. We will come to Corinna. We hope next time Corinna will be present to give answer to the questions. And we come back with our WFUMB webinar at 2nd December in the same structure. Before that date, we will have a discussion with the organizers in EFSUMB and WFUMB about the structure. Perhaps if we have more, please, could you open the windows and we can see who is from Europe of the participants? Yeah. It's easier to see who is not from Europe. Please give me an email if you are in chat. Who is not from Europe? Ahmad is not from Europe?
Yes, I'm from Malaysia.
Oh, that is a long way to go there. What's your time now?
Almost 10 p.m.
10 p.m. Okay.
11 p.m. 11 p.m. Sorry.
11 p.m. That's late.
Yeah.
Okay. Perhaps we come back to the other one. Very nice that you attend our meeting. The next one is Gang Shimek. You come from there? From where? Open your microphone, then we can hear you. Please open your microphone.
We cannot hear you.
We can't hear you.
But you are
Okay.
welcomed.
Welcome. Please put it in the chat. If you like, if you have some question to the first lecture, you will have to contact the WFUMB, yes, or if you like to see the other lectures we recorded, you please contact the WFUMB, that is administration there, and then they give us the information about that. Thank you, Alina. We are at the end now, and see you again in December. Good way home. Good
Thank
night.
you.
Mr.
Good
Good
night.
night,
Good night.
Mongolia. Good night, Japan.
Thank you.
Good night.